takeaway for frontal and sphenoid surgery. I'm going to go a bit quick so that I can make sure that we keep within our timing. So if there's anything that is too fast, that's something we can follow up on the lab or just stop me. I wanted to acknowledge some of the fellows who have helped me put together some of the images and videos that you'll see. I wanted to thank Greg for a great course and great content. And I want to say I had a chance to meet with all the faculty yesterday at the faculty dinner. This is a great group. If you find someone in the lab who you like learning from, keep them. Grab onto them, tell them, and stay there with you because they're all great and have tons of pearls to share. A disclaimer, today is going to be quick. It's just going to be some technique pieces. There's no p-values. It's more about pearls to, I think, achieve safe and effective surgery. We're going to start with the sphenoid, and I want to go quickly through this one because I don't find this part too controversial. One of the pearls that I've identified is locating the natural ostium. And so I think that the best landmark for me is the tail of that superior turbinate. We heard from Karina yesterday about the floor of the orbit. I think that floor of the orbit is a great one. It requires a lot of dissection before you get there. I think in things like skull base cases where I go straight to the sphenoid, we can effectively find the sphenoid natural ostium just by locating what turbinate positions look like, and so I'm going to show you that. And then safe enlargement of that sphenoidotomy should occur in an L shape, and I'm going to show you why. I rarely will enlarge the sphenoid in the sphenoethmoid recess, but for a lot of reasons, I think taking a portion of that superior turbinate down low lets me have access through my middle meatus, which I want to keep open at the end of sinus surgery, lets me surveil better, lets topical medication penetrate better, so resecting a portion of that turbinate has become fairly standard for my sphenoidotomy. I may skip over some of the challenges and pitfalls in sphenoid surgery, with the exception of where the position of the sphenopalatine artery branch that crosses the anterior face of the sphenoid is, but there's a lot of trouble inside the sphenoid. Sphenoid sinus, and so we talked a little bit about landmarks. I'm going to just be talking schematically about the adjacent to the tail of the superior turbinate, but also using that orbital floor, and Karina showed a version of this picture, I think, which kind of can show you the height of that orbit, and therefore where you want to be entering into the sphenoid itself. I've done this schematically to kind of show what it looks like when you're looking coronally with a 0-degree scope inside the nose. We see the inferior turbinate, the inferior meatus, then the inferior turbinate, middle meatus, middle turbinate, and as we go medial to it, you're going to see that superior meatus, superior turbinate, and can use those as landmarks. That's that sphenoethmoid recess where we find the sphenoid ostium. That's exactly where we see it, and then we should know that the artery branches that come from sphenopalatine artery foramen cross over the anterior face of the sphenoid just below the sphenoid natural ostium. That's it in the nose that you can see with a schematic overlay. That is the height of the floor of the orbit, although we can't see it there, to kind of give you some landmarking. This is looking at those exact same pictures going through the nose. Inferior turbinate, inferior meatus, zoomed in, middle turbinate, middle meatus, and in the distance we can see that superior meatus. Gives us some landmarking about where that is. Superior meatus, superior turbinate. As we get closer and closer, you'll see that actually if we look around that superior turbinate, most times we can appreciate where that sphenoid natural ostium is. Depending on how far Parsons Ridge takes us laterally, it can be more difficult, but you can get an appreciation of where that is, especially in an E-size patient, and you can lateralize these turbinates, you can find that sphenoid os. And so from a surgical step standpoint, we're going to talk about resecting a portion of that turbinate. Pretty good data to show that if you can leave at least a portion of the superior turbinate and take the inferior third or half, that you're not going to affect olfaction in a significant way. And then to enlarge that in a way that goes in an L shape towards the orbit inferiorly and towards the planum medially. And then we're going to talk about why in that shape. And that danger corner to be left at least till last or left alone at all would be superolaterally in red. Here's a sphenoid sinus surface anatomy of one that I surgically opened. This, you can see the optic nerve, you can see the carotid, at least it's genu there, and the optical carotid recess between them. You can see the sella there, and this is a three-dimensional space put onto a 2D diagram, just like it would be in the operating room. Just going to get my... Then the clival recess down below it. And so you can see that when we open into the natural ostium of the sphenoid sinus, that we're going to open down low and then enlarge it in an L shape because these two areas are relatively safe, whereas this area contains all the things that we don't want to be at, unless we want to do that last. I've included a video, and I think that what the video shows me is when we finish Winston's ethmoidectomy, is that we can kind of see that middle turbinate moving, but the structure behind it's the superior turbinate. It doesn't move when I'm touching that. When I go to the other side of the turbinate now, and we're clearing polyps from within there's a polyp case, you can see that I can see that sphenoid ostium and cut not at the level of that sphenoid os. And you can drop in one tine into there. Be careful when you're doing that, so you're doing that under direct visualization. And then another piece of this is that sometimes doing that helps with your depth of the posterior ethmoids. With navigation, you could tell that we probably weren't in that posterior most ethmoid cell, but this is another way, I think, nicely of kind of seeing that there's actually still a posterior ethmoid cell that had not been aerated, and removing that will show us that anterior face of the sphenoid and an os of the sphenoid that I had identified in the sphenoethmoid recess. I'm going to jump on that video. Oh, sorry. Sorry, I can't see it on my computer, so I have to use the screen above. Then enlarging that. Now, careful enlargement probably happens with a tool other than the microdebrider. Once I've gotten pretty comfortable with this, seeing my tool half in, half out makes me feel a little bit more comfortable under direct visualization. Kerrisons, I think, are a really good tool for us to be able to think about the next steps. Then you can create a postoperative healed appearance of a sphenoidotomy that looks like that. And we have that portion of the superior turbinate that's left behind. We have a part that was at the natural ostium. We can enlarge it to a larger piece. And if we have very severe disease, can think about paralleling the shape of the orbit, where inferolaterally it extends more laterally. And so you can kind of have a rhomboid shape if you needed to, like in this severe disease case where you wanted to create a more significant opening that follows the shape of that orbit posterolaterally. Okay, a quick run through about sphenoids, and I think it just shows us about the shapes. I think it would be about safe tools that you can use. I use the microdebrider there, but I encourage you to use hand tools. Stay low when you go lateral because the orbit swoops away from you, and all the important stuff like the optic nerve, carotid artery, or superolateral, and then identifying planum superomedially so that you can, after that, when you can have space to see, decide how much of that anterior face of the sphenoid you want to take while visualizing the things behind it. To get to frontals, I think that what you're going to see is this is a tough topic, and especially in a short period of time for us to have multiple variations in the frontal sinus anatomy make it tough. But we know that this is the place for the highest failure rates in terms of long-term patency, and therefore we want to try to create a maximal safe aeration. And so I'm going to overview some simple concepts for long-term success. Some of them are pearls that are about, you know, how are we going to achieve that maximal aeration? I think what we want to do is we want to remove all the ethmoid septations, which I call the inside walls, to the anatomical limits. So we're going to talk about what those outside walls are of the anatomical limits of your frontal sinus dissection, and leave those outside walls mucosalized, because it's great to get it maximally large. If you've stripped off all the mucosa, that is going to stenose and create a problem that you saw some slides of. Angled endoscopy and instrumentation Winston already alluded to, and I think it keeps us safe, and I'm going to show you how it keeps us safe. And angled instrumentation improves completeness, so I'm going to show you some instruments that I think are key to doing that. And then to start to think about some of the shapes that should be burned into your brain or what you're looking for. I'm going to try to show you. We all know this classification, and I think it has become a bit outdated in terms of we need to think about more than just the cellularity. I will say that there has been a more comprehensive cellularity discussion that happens, really separating cells into anterior and posterior cells that obstruct the frontal sinus drainage pathway. Schematically, I'll show you that here, where you see that there's an anterior cell and a posterior cell, and the frontal sinus drainage pathway is in between. There can be many anterior cells, and it really doesn't matter how many. It kind of matters how high they go, because how difficult it is to remove them to create that improvements, how big they are, like a type 3 cell that heads upward. Very similarly, that can happen posteriorly. There can be one cell posteriorly, a big suprabular cell. There can be a suprabular frontal cell that extends up into the frontal sinus, like a type 3 posterior cell, so that we have some idea that it really is that there is going to be anterior cells and posterior cells in the frontal sinus drainage pathway in between. We want to know that when we're looking through our anatomy and our imaging. But, you know, from a maximal aeration standpoint, I think it matters, but does it really matter? Because my goal is really to find those 4 outside walls. And so I'm going to introduce what I think is a bit of a paradigm shift in terms of trying to identify what traditional frontal sinus surgery and dissection is, an expansion or dilation of that frontal sinus outflow tract. What I kind of want to see happen from a comprehensive standpoint when you need it to be maximally ventilated and aerated is that we're going to maximally remove those septations to the safe walls of the orbit in the middle turbinate. So that we get a maximal aeration. You know, we think about the draft extent of frontal sinus surgery, and it always is just in a coronal plane. Take some of the turbinate, take the intersinus septum to get across the other side. But what about that sagittal plane? I'll tell you that I think it's just as important for us to think about that you got to take away all the septations of these cells, because that's what creates a maximal aeration plan for the frontal sinus. And what that shape is kind of like a funnel. And so when I teach this, I say, don't create a tunnel into that frontal sinus, create a funnel by removing all those septations in a safe way so that we can get maximal aeration of that. Here's another good example. If you took away the agar-nazi, you can get a tunnel into that frontal sinus and you'd have something that looked like that. But if we start to think about the fact that all those septations need to go back and maybe we need to skeletonize that anterior ethmoid artery, then we want to really create a funnel in that by removing what's in the blue there and doesn't show up well. But that is going to be what finds it, and that's going to help us identify that anterior ethmoid artery. We're looking for that in that dissection because we know it's going to be in the back of that funnel, and then that's going to create that whole shape of the frontal sinus and the half horseshoe, which we're going to talk about more. Frontal sinus surgery, in terms of a change in paradigm, makes it so that that healed appearance of that tunneled shape into the frontal with a circular opening, which may be appropriate in some cases, or a maximal aeration where we see it taken all the way a funnel to the anterior ethmoid artery and has that similar to half horseshoe appearance. So I propose a new definition of a maximal type 2A frontal sinusotomy where we think about that frontal recess in 4 sides, not just middle turbinate to orbit. And schematically, I'll show that here, where that frontal sinus outflow tract is separated into 4 walls. One, the anterior wall is the frontal beak, the back side of the frontal beak, which we want to keep mucosalized and defines our anterior border where we can't come past because that needs to stay mucosalized. The yellow is the orbit being our most lateral part of our dissection. The medial part of our dissection, the middle turbinate, and so that vertical lamella of the middle turbinate, and then the sloped one posteriorly. See that it's sloped, and in the operating room it looks in a weird direction, so that's something we should look at in terms of the posterior table. At the bottom of that posterior table is exactly where we're going to find the anterior ethmoid artery, where the skull base starts to slope up from the posterior ethmoids into the posterior table frontal sinus. And so that is exactly what I think is a better paradigm to thinking about the maximal space that you have, and I'm going to try to show in the lab how to identify those 4 walls and then remove the septations inside it. And so it doesn't matter what kind of cellularity you have there. In the end, if I want to create a maximal frontal sinus aeration picture, I want to remove the entirety of that cellularity and leave them walls mucosalized so that we get a maximal drainage pathway that's there. And if I look at that there, that's blue anteriorly, yellow for the orbit, green for the middle turbinate, and then we find anterior ethmoid artery at the base of our posterior table of the frontal sinus, and we're going to create that funnel in frontal sinus surgery to get maximal aeration of that frontal sinus. So from a surgical step standpoint, let's try to look at it. When we start our frontal sinus dissection, we're looking up with an angled endoscope, and I'm going to show you why we're going to look up with an angled endoscope. When we're looking for that anterior wall, actually is anterior on the screen is that frontal beak. The orbit is the whole thing lateral to us. The middle turbinate we're between. And if we can identify what those are, we're going to keep ourselves safe because everything bad happens there. And then where the anterior ethmoid artery is, I'm going to try to show us in the lab how we identify where the takeoff of the skull base is and that anterior ethmoid artery is located. If you do that, then we can see all this cellularity, and I think it's important to point out, and usually we can find a medial mucosal junction. That medial mucosal junction is between the anterior cells, the middle turbinate, and the posterior cells to create a space that would take us right up to the frontal sinus, and I'm going to try to show some videos of that. And then we're going to remove the entirety of that cellularity to take us to the anterior beak, take us to the anterior ethmoid artery, and make sure that we're staying within the middle turbinate and the orbit sidewalls. That shape is that half horseshoe that I've alluded to, and so that's kind of the shape of when you're trying to create that shape at the end, what you want to see. From a key concept, I've added a couple pearls here that I think have helped me think about how to achieve what I just showed you. One of them is the importance of angled endoscopy. From a schematic standpoint, we can use a 0-degree scope, and you can see that when we remove the agar-nazi cell, we can be looking right into that frontal recess, but it's hard. You're kind of always looking up to try to see up into that space. You can appreciate that the frontal recess is there, but you can't actually see the frontal sinus. You know that it's there. With the bulla intact, it would be right going through there. When you put on an angled endoscope, that view changes, and what you're really seeing is you're seeing up into the frontal sinus from below, and the anterior ethmoid artery becomes at the back of your dissection. I think what this does is it forces us anterior. This scope forces you to be working more here as opposed to working here, where that trifecta of problems that Winston talked about happens at that anterior ethmoid artery. And so instead of having a view like this, which I think is possible with the 0-degree scope, and we talk about sometimes creating axillary flaps or removing a portion of this agar mound, instead I think you can use the scope to be able to see into that. Start with something. Start with a 30. That makes it easier. So you start to get more and more. I'd say the more angled, the safer. Everything is directing you anteriorly, staying away from the cranial base. The next thing is about preparing your runway. I think one of the things that was important for me is I talked about addressing septal deviation, so I won't again, that I think it helps us in terms of mobility and instrumentation, especially when I'm trying to deal with complex frontal sinus cellularity. A complete unsonectomy, and I think Winston showed this very nicely, the idea that where that unsonet is, and that if we're trying to get to a place where we're going to do it well, if we can remove that unsonet really well, it sets us up for our frontal sinus dissection. And so you're going to see me try to remove the unsonet in one piece here just to give us an appreciation that that anatomically looks like what an unsonet should in Winston's great anatomical diagrams. You should be able to take it off with a free edge posteriorly, and that when you're looking at the bottom edge, you should see the natural ostium of the maxillary sinus, and at the top, what we can do more. This is that extended unsonectomy concept, and I'll tell you that this requires a caveat because you got to be careful in this area. But if you can remove some of the portions superiorly and superior laterally, that this can put us right into the frontal recess and make it very easy to do our dissection later. Here is the unsonet. Here's that extended unsonet or an axilla of the middle turbinate region that you can remove. The idea schematically, so that I can show it, is that, we see this portion of bone that overlies the nasolacrimal duct. Karina called it the nasolacrimal protuberance. I call it the lateral beak because I think it made more sense to me to think that it was a beak laterally, that just like there is anteriorly. And so when you can remove some of that safely, that you can get right onto your medial orbital dissection, you can get very high into it. And so what you end up having is that kind of appearance when you're able to remove and make more of a keyhole as opposed to a triangular space. And so when that heals, I think that it has some benefits. It improves visualization, it improves flushability and flush trajectory of the frontal recess. What it comes with some downsides about minimizing scarring at the middle turbinate. So there's a lot of products that exist for us to minimize scarring and synechial formation, and there's risk to the orbit and nasolacrimal duct when you do this. And so that's what that healed look looks like, but you're looking when in the clinic right at the orbit and right into the frontal recess. And so you can kind of see that with a scope in the clinic to see that kind of thing. You know that your flushes, your sprays, your medications of all varieties are getting up into the places you need them to. Armamentarium, to think about some of the tools that you need, and I encourage you to find them in the lab, are that what do you need to have? Well, there's a whole host of frontal sinus tools, and it's hard because I think I show this slide to people and they say, not at my hospital, that's not what the armamentarium looks like. I'll tell you that I think that there are some basic tools that you need. And I would say that the most basic are understanding how to use your angled microdebrider blades. And you'll see that I use an exaggerated angled microdebrider blade. I use a 90 because what it does is it keeps me more anterior. Just like my 70-degree view makes me stay anterior, so does my 90 microdebrider blade. And then some of the tools like the Hoseman and the Cobras that you see at the top are sort of you need. The reason I really like the angled microdebrider blades is that they can rotate. And so it's finally a tool that helps me deal with septations like these if they're soft enough. And if they're not, you need the hand tools that I showed you the set of, which is very difficult. But it's a tool that lets me cut anteriorly when I need to deal with the anterior cellularity, cut posteriorly when I need to deal with the posterior cellularity, so that I can get that maximal aeration that we were talking about. The Hoseman is something that I think does the same thing, cuts 360. You have to have enough space to put it in, but really good when you have hyperostotic frontal recess septations. And that's another one that goes right into that frontal recess, lets me cut anteriorly when I need to, or cut posteriorly. Okay, I'm going to have a couple videos with our last 3 minutes about putting it all together. There I planned out surgery and defined the cellularity with a very big suprabular frontal cell, a superagar frontal cell, and then the small frontal sinus ahead of it. I'm going to find those four walls, which I identified, and I'm going to cut right next to the orbit. So I'm going to say I'm never going any more lateral than this. And that I can cut away some of the cellularity at the front wall of that suprabular frontal cell because I knew that the frontal sinus was anterior to it from my anatomical review or intraoperative anatomical review with navigation. Here, using a microdebrider to see that space and take that wall back to the posterior table and seeing that partition that exists between the suprabular frontal cell or supraorbital ethmoid. Here, using a Hoseman punch to try to remove that septation. What's really notable is the anterior ethmoid artery that you can see that I identified and preserved and knew exactly where it was that whole time because it was hanging in that case. But it turns that cellularity, which you can't really tell which one of those is, to a open half horseshoe. We're going to try to see that again and see if I see it again in another case. Identifying the cellularity before you're there. Try to figure out exactly what you're looking for. Again, try to find those four walls, middle turbinate, and be cautious about preserving it. Cutting next to the middle turbinate so I can say, I don't want to go any more medial than this. This is it. And I'm going to find that triangular space that I told you about. and then take all those septations from the middle turbinate towards the orbit, taking out internal walls, inside walls, the little bony bits you can take out with small giraffes, and then leaves you mucosal bits that you're able to take with your microdebrider. And then what lets you get into that frontal sinus that you can see there, using some of the Hosman anteriorly to think about, can I make that larger and make it so that I'm not just ventilating that suprabular frontal cell here, but I'm actually creating a half horseshoe that goes from orbit to anterior ethmoid at the back. This is some stenting because I wasn't so happy with how careful I was with the mucosa, and so that's a silastic stent I use in that setting to try to help with healing, something we can talk about further. Sorry, one last case, I think. Looking at the anatomy ahead of time, trying to identify for myself exactly where we're going to see and where we're going to be. I'm going to look again for figuring out where that orbit is and find that triangular space between the anterior cells, the middle turbinate, and the posterior cells. That will take me right into the frontal sinus outflow tract. I can remove some of the bony partitions after I've broken them, and image guidance can help us confirm we're in. There's that posterior septation, which is making it so that I can't get that complete skeletonization of the posterior table of the frontal sinus. I'm removing it so that we can make sure we can get all these partitions in that half horseshoe appearance that I think we're going to try to see in the lab today. A bit of a whirlwind about tools, concepts, and dissection techniques in the frontal sinus, something I'm happy to review in the lab, or as I said, if you find someone that teaches and explains something the way you like it, hold on to them, because all of these guys are great surgeons that have a lot to share.